Good evening. My name is Rick Zinke, and I am a medical oncologist with Compass Oncology and part of the Compass Breast Specialist Program. Tonight I'm going to be talking about your breast cancer, your therapy. As we begin, we're going to review a few breast cancer statistics, followed by a little discussion of how breast cancer behaves in the body, how this shapes our treatment recommendations, and how we make decisions about appropriate therapy for an individual patient. So breast cancer continues to be a very common cause of cancer in the United States. It's estimated, according to the American Cancer Society statistics, that in 2017, over 250,000 new cases of breast cancer will be diagnosed. It also is the second most common cause of cancer-related death in the United States, with an estimated 40,000 cancer-related deaths due to breast cancer this year. 1 in 8 women in the United States will be diagnosed with breast cancer in their lifetime. Most of these diagnoses occurring before the age of 70. So breast cancer remains a real problem, and we are continuing to make efforts to optimize treatment to improve outcomes for all women diagnosed with breast cancer. Breast cancer begins as a single microscopic cell in the breast. As this grows, more cells collect and clump together, forming a lump, mass, nodule, or tumor in the breast. Over time, some microscopic cells may separate themselves from the lump and make their way to other parts of the breast, into the lymph nodes under the arm, or beyond into other parts of the body, such as the liver, the lungs, the bones, or even the brain. When a woman undergoes surgery, all the grossly visible disease is removed from the breast. But this does nothing to take care of the microscopic spread of disease to other sites. In order to take care of these other sites of disease, and with the goal of eradicating any of these microscopic sites of disease, we can use other therapies, including chemotherapy, targeted therapies, radiation therapy, or hormonal therapy, also known as anti-estrogen therapy. The purpose of these additional therapies after surgery is to eradicate the disease, reduce the risk of it recurring, and increasing the chances of breast cancer cure. Traditionally, it has been somewhat difficult to predict the risk of breast cancer recurrence after surgery. And we would have to rely heavily on features of the breast cancer itself from the pathology following surgery. When a woman would ask, do I need chemotherapy, we would have to rely on the tumor size, the grade of the tumor, the status of receptors known as the estrogen receptors, progesterone receptors, HER2 receptors, and the lymph node status. In the not too distant past, if a woman's tumor was over 1 centimeter in size, she had adverse receptor features, there was a high grade, or there was any evidence of lymph node involvement, she would receive chemotherapy. As you can imagine, many women received chemotherapy. As far back as 1989, a landmark study was published, which demonstrated that in 100 women treated with tamoxifen, a hormonal therapy, without chemotherapy, who had estrogen receptor positive breast cancer without lymph node involvement, at 10 years, 85% of them had no signs of cancer recurrence. With this information, it was concluded that if all of these women had been treated with chemotherapy, that 85% of women, those 85 women, would have been overtreated with chemotherapy, having not needed it to reduce the risk of breast cancer recurrence. So this, along with other studies, sparked efforts to try to optimize our way of determining who could benefit from chemotherapy and who would not. Advance a little bit to the genomics era. With advances in genetic testing, we've been able to fine-tune our understanding of diseases such as breast cancer with a test called the Oncotype DX assay. the breast cancer DNA itself is tested for 21 different genetic mutations. 16 genes that are cancer-related and 5 that are housekeeping genes. This test looks for a pattern of genetic mutations. And with this pattern of mutations, it assigns a recurrence score. But who's eligible for a test like this? This is designed for women with early stage 1 through 3, estrogen receptor positive, HER2 receptor negative breast cancers, which actually comprise about 75% of breast cancer cases. Also, these tests are available for those women with both lymph node positive disease and lymph node negative disease. So when we're trying to answer that question, do I need chemotherapy? We don't have to rely on the pathology alone. We can turn to genomics. And through looking at the woman's breast cancer's DNA, we can answer a few key questions. We can determine what the prognosis is, which is given to us in the form of a recurrence score, telling us the likelihood that this cancer will behave aggressively, leading to an increased risk of recurrence. It'll also give us a predictive score, or a predictive measure, telling us whether this particular breast cancer is likely to respond to therapies such as chemotherapy. If we look at a score report, you can see that it gives a recurrence score result. In this case, the score was 9, which correlates with a 10-year risk of distant recurrence, which is a risk of recurrence in a distant part of the body outside of the breast. When it recurs in a distant part of the body, that is a stage 4 recurrence, and unfortunately that stage is not curable. So we like to do anything we can to prevent that type of recurrence. This woman's score of 9 translates to a 10-year risk of distant recurrence of roughly 6%. Now this assumes treatment with hormonal therapy in the form of tamoxifen, because all cancers tested in this study and all cancers that are eligible for this test are estrogen receptor positive, and that is standard therapy for them. So this tells us the prognosis. What about that predictive element of it? The score report will also give us that information. So in this patient with that score of 9 and that 6% risk of distant recurrence, you can see, if we look at the dark thick line, which is the risk of distant recurrence with tamoxifen alone, and compare that to the dark dotted line, which is the risk of distant recurrence with tamoxifen plus the addition of chemotherapy, you can see that there's no significant difference for her between those two lines. Let's imagine that she had a score of 40. If she fell at a score of 40, her risk of distant recurrence over 10 years would be roughly 24%, much higher than the score of 9. And that's with tamoxifen alone. In that situation, if you add chemotherapy, that risk drops considerably to about a 10% risk of distant recurrence. In that situation, the benefit of chemotherapy is significant, and it would be recommended. In the original situation with the score of 9 and no perceivable difference between chemotherapy use and not using chemotherapy, chemotherapy would not be recommended. Generally, this report breaks things up into the low-risk group, intermediate risk group, and high-risk group. The benefits of chemotherapy are clear in the high-risk group. They're not present in the low-risk group. In the intermediate risk group, it's a bit of a gray zone still. And studies are ongoing to determine how we can better identify who in that intermediate risk group will benefit from chemotherapy. Studies have actually demonstrated that over 50% of women tested with this study will actually be in the low-risk group, with approximately 27% in the intermediate risk and 22% in the high-risk group. But how did this change things over time? Or how did this change things compared to when we had to make chemotherapy decisions in the pre-genomics era. A study published in 2013 demonstrated that when you looked at the decision for chemotherapy without the Oncotype DX test, compared to the decision for chemotherapy in that same group of women with the Oncotype DX test, the decision to provide patients with chemotherapy changed in 26.8% of cases. The majority of them ended up not receiving chemotherapy after they initially would have been recommended to receive it. In a few cases, they did actually recommend that they should receive chemotherapy, having identified a higher risk for recurrence than their initial pathology had recommended. This is really showing that we can fine-tune decisions for chemotherapy on a case-by-case basis. So today, in the genomics era, we are able to fine-tune our treatment recommendations for each woman on a case-by-case basis. With this information, a woman can feel confident that she is getting the right treatment tailored specifically to her and her particular breast cancer. More efforts are ongoing in the genomics field, not just in breast cancer alone, but in all sorts of other cancers to help us fine-tune our ability to treat the individual patient in an individualized way. At Compass Oncology, we are using this test and other tests to take care of our patients as an individual. If you are interested in more information, please visit compassoncology.com.